Welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you're attending virtually and have a question, please enter it into the Q&A segment, and if you're in person, we'll hold our questions until the end of the talk. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker today, Dr. Tosan Ejutse. Dr. Ejutse is a dedicated physician originally from Delta State, Nigeria, who migrated to the United States approximately 22 years ago. With a deep passion for preventative medicine and a constant curiosity about the wide spectrum of diseases encountered daily in clinical practice, Dr. Ejutse chose to specialize in internal medicine. As a strong advocate for proactive health, Dr. Ejutse is committed to addressing medical concerns that significantly affect both their own family and the broader patient population served. Today's presentation will focus on a foundational topic within internal medicine, underscoring its relevance and impact on diverse communities. Join me in welcoming Dr. Ejutse.
Alrighty, good afternoon, everyone. My name is Tosan Ejutse. I am a PGY3 internal medicine resident, and my mentor is Dr. Parvikar. Today, I'll be talking about clinical and technological advancements of diabetes mellitus in primary care setting. As Jennifer mentioned earlier on, I have no disclosures, financial disclosures, gain, or interest in this presentation. So my objectives today are discussing medical management of diabetes mellitus, discussing personalized treatment plans based on comorbidities, cost, as well as patient preferences, discussing continuous glucose management, which is the CGM that you see there, as well as providing feedback to providers after 6 weeks of obtaining clinical data via CGMs, and also listing chronic disease management that patients can access as far as diabetes education goes. So, diabetes mellitus. It's a chronic disease defined by the impairment of insulin secretion or insulin resistant. It's categorized into 4 categories, one being iatrogenic diabetes mellitus, which is basically multiple etiologies that causing diabetes mellitus itself, type 1 diabetes mellitus, type 2, as well as gestational diabetes. Some patients are symptomatic or not symptomatic. The asymptomatic patients usually just present with hyperglycemia, noted on multiple metabolic panels, indicating further management or workup via the physician, usually the primary care physicians. Other patients experience a range of symptoms, including polydipsia, polyuria, weight gain, loss, as well as UTIs as well, and visual deficits. Alrighty. So going to a little bit more of the prevalence of diabetes mellitus, I think this went back. Okay, here we go. In 2021, the prevalence of diabetes mellitus in the US reached about 38.4 million people, both undiagnosed and diagnosed. It affects all communities, but more specifically in the Black, Asian, and Hispanic communities, leading the majority. Per American Diabetes Association, for this year, well, last year going into this year, about $412.9 billion has been spent on the treatment of diabetes mellitus. Psychosocial factors that contribute to the prevalence of this are socioeconomic statuses, access to healthcare, food insecurity, as well as health literacy. So now this chart shows the prevalence of the total diabetes among adults who are 18 years or older from the year of 2017 to 2020. I just want to point your direction to where the asterisk signs are. So going down the first column, basically showing 14.2% of the total population of diagnosed diabetes noted to be in patients who have a high school degree or less. And then going over to the third column for the Black and Hispanic population being the highest prevalence of diabetes mellitus within the US. So these are noted risk factors for diabetes mellitus, being overweight or obese, defined by a BMI of 25 or greater, family history of diabetes, history of prediabetes hypertension, dyslipidemia, others may know that as high cholesterol, gestational diabetes, or being an infant to a mother who went through gestational diabetes herself. And then high-risk populations, like we mentioned earlier on, with Black, Latino, Native Americans, as well as Asian Americans being high-risk populations. And then history of HIV. Also, patients who are on certain protease inhibitors, as well as NRTIs, and patients who also have periodontal disease are seen frequently with higher BMIs, whether it be hyperlipidemia or hypertension, also have risk factors to diabetes. And then patients who unfortunately have also suffered from pancreatitis. Okay, so now we're going into the pathophysiology of this. Please bear with me. So for the type 1 diabetes mellitus, this is more so an autoimmune discretion of the beta cells of the pancreas, resulting in more so insulin deficiency. Once diagnosed, patients are usually tested with autoantibodies. There's 3 significant ones: the GAD65, which is the glutamic acid decarboxylase, the tyrosine phosphatase, insulinoma, associated protein A2 antibodies also tested. Usually this is seen in younger populations, patients who are younger than the age of 25, underweight, and then have somewhat of family history, but not as prevalent anymore. And then for type 2 diabetes mellitus, this is multifactorial. This can go from environmental risk factors to pathophysiologic risk factors as well, leading to insulin resistance and impaired insulin secretion from pancreatic beta cells. Most patients are usually middle-aged or elderly population, overweight, obese, and they have a prevalent family history. Alrighty, so this is going a little bit more into the algorithm of the pathophysiology and then how we diagnose patients. So starting with patients that we're suspecting are type 1 diabetics, this could be an 18-year-old female that comes in and tells you that she's having polyuria, polydipsia, and then you test for the islet autoantibodies and it comes back positive. You can just confirm type 1 diabetes mellitus and go down the algorithm for that. And then patients who come back negative, and then you see their age, so let's say this is a patient who you were still suspecting may be having type 1 diabetes, but let's say she's 26 years old, having the same symptoms. You go down to the next slide, which goes into the age brackets. So for those, there we go. For those who are diagnosed less than 35 years of age, who have no clinical features of type 2 diabetes or monogenic diabetes, a negative result usually results in the change of diagnosis to type 1 diabetes, since about 5 to 10% of those have a prevalence of type 1 diabetes. Monogenic diabetes basically suggests the presence of one or more features, being hemoglobin A1C less than 5.8, and then another hemoglobin A1C of less than 7.5. And then on top of that, you also have a parent who is diabetic but has type 1 diabetes and confirmed. And then you also have patients who have renal cysts, partial lipodystrophy, maternal inherited deafness that gives a risk factor to type 1 diabetes. And then going back again over to the other side, where you have patients who are over the age of 35 years old, they make a clinical decision based on trial of non-insulin therapy. So that could be oral anti-glycemic medications with metformin, GLP-1s. And then you can consider doing a C-peptide test. Depending on the range, you can either confirm type 2 diabetes mellitus with a range of over 600, or you can just say more than likely they're still type 2 and just continue to treat them that way as long as their A1C is improving. Alrighty, so this is the diagnosis per the American Diabetes Association, and then I'm going to show you the next slide, which also shows you the classification of the 4 different types of diabetes mellitus. So you have to have an hemoglobin A1C of 6.4 or more. You have to have a fasting blood glucose or plasma glucose of greater than 126 twice, or you have to do an oral glucose tolerance test, usually seen in a pregnant population, and have a glucose of above 200 or with a loading glucose of 75 grams usually used. Then you have patients who come in symptomatic and then they have a random blood glucose done or random plasma glucose done of above 200, and then you can diagnose with diabetes as well. So this is the table I was alluding to with the 4 different classifications of type 1 and type 2, as well as the gestational diabetes and other types. So the other types kind of elicit or allude to people who have cystic fibrosis, so risk factors to having pancreatic insufficiency, people who have had necrotizing pancreatitis, so that would be the last section of this table. So these are the interventions. So we're going to go from lifestyle, pharmacological interventions. We're going to go to technological interventions as well. So for lifestyle interventions, I just want to point your direction or your attention to the first four, which is basically where the lifestyle interventions come into play. This would be with nutrition, physical activity, sleep, and as well as counseling. Diabetes and nutritional education to promote positive behavior is number one. Number two, physical activity is also recommended about 150 minutes weekly, as well as 30 minutes daily for 5 days a week to promote weight loss, as well as promote the decreasing of hyperglycemia into and uptake into the tissues. And then also the Mediterranean diet, as well as the ketogenic diet are also recommended for in treatment of patients with diabetes. However, the ketogenic diet is not recommended for patients who do have dyslipidemia. And then on top of that, you also want to take into, again, the psychosocial support, addressing access to healthcare, food insecurity, as well as cultural preferences that may help patients with diabetes mellitus get better, as well as control hyperglycemia better for them. So then we are not talking about the pharmacologic. This is going to take a couple of slides as well, so bear with me. First line for oral anti-glycemic is usually metformin, still pretty standard. It increases insulin sensitivity by decreasing abdominal glucose absorption as well as hepatic glucose production. As far as metformin goes, the benefit in treating hyperglycemia as well as a weight loss benefit has been proven over the last 10 to 15 years, more so than later on. And then on top of that, you also have your SGLT2 inhibitors, usually known as Farxiga, Jardiance, as well as Invokana. This reduces your renal sodium as well as glucose reabsorption and increases urinary glucose excretion. Unfortunately, with these seen, sometimes you do have patients who have recurrent UTIs as well as yeast infections, so you do not want to prescribe these medications to those patients. But this medication or this group of medications are actually very, very good in treating hyperglycemia. They're cardio and renal protective, even more than metformin. Adverse effects for metformin, as we usually know, which is why we don't prescribe it while we're inpatient, lactic acidosis, but on top of that, patients do have GI intolerance with diarrhea. For the SGLT2 inhibitors, we spoke about the yeast infections and the UTIs, but also with patients who have worsening CKD, unfortunately, you can't use these. This is usually for people who have CKD stage 4 and above. Cost for metformin is actually pretty affordable, which is good. With insurance, it's about $5 a month, or it could be fully covered. For the SGLT2 inhibitors, these are a little bit more expensive, so you have to be a little cautious of what your patients can actually afford. Without insurance, these are about $600 a month, versus with GoodRx, $280, which is still a good discount. Going into your GLP-1s, so you have your Ozempic, semaglutide, your Trulicity, dulaglutide, liraglutide, and then there's some other new ones who are coming on market right now, but have not fully been approved by FDA. They increase insulin secretion, delays gastric emptying, as well as inhibits glucagon release. Unfortunately, the adverse effects of these are not necessarily astronomical, but they're a decent side of these adverse effects. But the benefit does still outweigh the risk. The adverse effects include ileus, pancreatitis. Patients who have medullary thyroid cancer, unfortunately, should not be on these medications. Biliary disease with cholestasis, diabetic retinopathy, usually in patients who use this for more than about 10 years. And then, unfortunately, they do have the prominent GI side effects with gastroparesis, nausea, vomiting, diarrhea, or constipation. The costs for these are also, unfortunately, not the best. With Ozempic, without insurance coverage, they can range from $850 to about $1,000 monthly. With Wegovy, also about the same, just a little bit more, about $1,300 monthly. Pharmacological interventions continued with more GLP-1s as well as GIP. So this is where we have a little bit more evidence-based medicine with Mounjaro and Zepbound being able to treat diabetes mellitus. So the adverse effects, again, they're about the same as the first ones, which the GLP-1s with the Ozempic, liraglutide, as well as Trulicity. Zepbound without insurance itself costs about $550 monthly. Depending on commercial insurance, you can get it covered to about $25 monthly, or with a 3-month prescription as well. And there's some pharmacies who do offer clinical cards that can help with discounts for them. Mounjaro, unfortunately, is the most expensive one, but it has shown a lot more evidence to help control diabetes. Mounjaro without insurance is about $1,200 a month, depending on who the provider of Mounjaro is. Then you have your DDP4 inhibitors. This is your saxagliptin, your Januvia, increases insulin synthesis as well as release. Okay, and going a little bit more into the adverse effects of this is your pancreatitis is again reported with these, but not also always seen as the causality. Sometimes it could just be the normal root cause for pancreatitis, which is gallstones or hyperlipidemia or any other issues outside of you being on these medications. The cost for Januvia, again, without insurance, is about $600. For the other ones, they're available in generic forms, and they're usually covered by insurances. Then you have 3 more groups of medications with your thiazolidines, as well as your Actos, which is more so commonly used. It increases insulin sensitivity. However, the adverse effect of this is weight gain. On top of that, with other groups of these medications, you have seen heart failure or the potential risk of heart failure with these medications as well. Sulfonylureas, which are not usually one that primary providers do prescribe for as first-line medications, but as an adjunct medication, it does stimulate your pancreatic islet beta cells to increase insulin release. Now, unfortunately, the adverse effects of this as well is hyperglycemia as well as weight gain. And then you have your insulin. This ranges from short-acting, long-acting, continuous peripheral glucose uptake, which it helps increase peripheral glucose uptake, inhibits lipolysis, proteolysis, as well as hepatic glucose production. Unfortunately, as we all know with insulin, there is a high risk of hypoglycemia as well as weight gain. So you can have patients who are on insulin and GLP-1, and then they come to you and they ask you why they're not losing weight. This could be one of the root causes as to why that's not happening. Now we're going to go into our technological advancements. There are different types. More commonly, the ones that we use right now are the continuous glucose monitors, which basically go with different brands, Freestyle Libre, Dexcom, Medtronic, and there are 2 more who are coming onto market right now, but have not been approved by the FDA. And then there's continuous subcutaneous insulin infusion, which is your insulin pumps, as well as the automated insulin delivery. We haven't used these much in the last decade or so. There are still some providers who do prescribe this, but mostly in rural locations. So going into the types of the continuous glucose monitors, we have the real-time CGMs, which displays as well as measures your glucose continuously, so you can measure it any time of the day without having to wait a period of hours. And then you have your intermittently scanned CGMs, which measures glucose continuously, but you have to scan it and save the values in order to know the data. We also have your professional CGMs. Devices are all placed by healthcare professionals, so in the clinic, whether it be by the provider or with nurses. And then data is collected within about a week or 2 weeks. But usually the data is blinded to the patients, so it doesn't necessarily, stop them from wanting to use this. But obviously, you still want to make sure your patients have the autonomy to know why you're blinding them from that data. And then you have your over-the-counter continuous glucose monitors or the biosensors. These are not actually seen as much anymore in your nearest pharmacies or nearest grocery stores. However, they do measure glucose continuously and they display the values multiple times daily. So going into a little bit more, there we go, okay. So this picture basically shows you one of the continuous glucose monitors, which is the Dexcom. This is more prevalently used than the Freestyle Libre or the Medtronic. I do want to point your attention to this last column right here where it says it's not approved. The G7 actually has been approved by the FDA to use in April of this year, I believe. And that's usually now more preference by patients, shall I say, when providers are prescribing these CGMs. So these CGMs, from what we can tell, as far back as 2002, actually, but Dexcom itself actually started back in 2006. And let's see, yes, 2006. So these are the benefits of the CGMs. Overall benefit is it helps patients who have dexterity issues, poor circulation issues, also creates a shared decision between providers and the patient, building patient rapport, and helps with mistrust with medicine, especially in patients like the Black and Hispanic population who have gone through, unfortunately, some historic issues medically in the US. Helps with enhancing behavioral responses when patients can link their hypoglycemic symptoms to the actual low glucose symptoms they'll be feeling. Usually known as dizziness, lightheadedness, having the sweats. So they're able to now kind of see, okay, how do I feel when I have my low glucose readings? Alrighty, limited side effects of the CGMs, not much, but the noted ones are contact dermatitis, usually seen with isobutyryl acrylate. It's an irritant that usually just causes erythema. Some people use Benadryl, but usually not had to be used. Give it 6 hours or so, and it should basically clear up. But for those who have noted a significant side effect like anaphylaxis, obviously we do tell our patients to not use these anymore. When it comes to the adverse effects noted, as far as anaphylaxis goes, it's less than 1% with CGMs. Medications that you can also add on to this with CGMs are the hydroxyurea, IV mannitol, solute, or peritoneal dialysis. These all tend to kind of cause a increase in your glucose readings. So those patients who are on peritoneal dialysis, patients who are on hydroxyurea for whatever with are certain diseases or IV mannitol inpatient, you can tend to have increased glucose readings for this. Alrighty, so these are the other CGMs, or not necessarily CGMs, but glucose monitors that we can use, and as well as used to administer insulin with our continuous subcutaneous insulin delivery, as well as the automated delivery. Both of these methods are used to deliver insulin mostly in younger patients and patients who don't have the ability to check their glucose multiple times throughout the day, especially those who are in high school playing sports and those who are type 1 diabetes. Also with patients who have poorly controlled type 2 diabetes with a hemoglobin A1C of 9 or above. The AID, like I said, is not necessarily used anymore, but they do use these in pregnant patients that don't necessarily meet the criteria of having specific glucose goals after being diagnosed with gestational diabetes. Again, these are not preferred in comparison to CGMs, but we do use them. And then the other two methods of delivery that have been widely studied in the US over the last 45 years at the very least, uses automated insulin delivery versus the CI2 to basically help with the ability of adjusting insulin doses and preventing hypoglycemia versus hyperglycemia. Per the recent 2024 systematic review report, we're using over 171 patients. The automated insulin delivery has showed clinical benefit in improving A1C, as well as psychosocial benefit when it comes to cost with our patients, especially in the type 1 diabetes population. Let's go back. Okay, future interventions. So within New England Journal of Medicine, there's this new article. It came out 2 years ago in June, and basically is suggesting, not necessarily FDA approved yet, suggesting Isodic, which is basically an insulin that's given weekly instead of giving daily. And let me go back to it. So these results are not necessarily clinically significant, unfortunately, with a p-value of 0.08%. However, the once weekly treatment did show promising advancement towards efficacy of glucose lowering methods, as well as better control in type 2 diabetes patients. Unfortunately, this did not test in type 1 diabetes patients, but this is a potential intervention that we could use for patients later on down the line. And then this is another one that was recently brought to me by the FDA, just approved actually. It's called Eversense. It's another continuous glucose monitoring system. This is actually an implantable device that you implant just right under the skin, and you change out every 6 months. And then all you have to use while you have the 6 months is a sensor that lets you know what your glucose shows. And then there's obviously an app that's also linked to this Eversense CGM. So basically, this small sensor is implanted, like I said again, under the skin by a doctor. So this would be used as one of the professional CGMs. The light signal is usually converted into a glucose reading wirelessly every 5 minutes, so the user has a smart device that they can use to be able to tell them, whether it be their cell phone or another transmitter device. And it has an app that you can program as well for this. The system can alert users when glucose levels are approaching either dangerously low or dangerously high, so they can have a more of a lead time to basically treat their symptoms or whatever number they may be about to see. So overall key points of this, diabetes mellitus is a preventable disease for those that are not environmentally or physiologically affected. Due to its growing prevalence, there is an emphasis on education and treating this disease as early as possible to reduce the risk of complications. The best interventions to date are lifestyle modifications, and then you can add on your pharmacologic medications as well as technological interventions as a close second. In our current times of technological advancements, providers should be open to using these interventions to overall enhance our goal of better diabetes management, especially, I apologize for the spelling there, but especially in those who are in the primary care setting and need better intervention for that. These are my references, and special thanks to Dr. Parvakar, Dr. Gabriel Valles, and Dr. Gross for this mentoring. And any questions?
Hey, I was just curious, can you give me an example of a time that you'd want to blind somebody to their CGM like data? And how that discussion would play out, I guess, in a primary care setting?
So this is a little touchy subject because obviously, like I said, you always want to give your patient autonomy. That is one thing that medical ethics as far as goes, we always want to make sure we are telling our patients why. But this can come to patients who have comorbidities with generalized anxiety disorder, patients who tend to want to have more of a psychiatric side effects, shall I say, to what we're suggesting. So in order to tell them, hey, in order for me to provide better management to you and decrease how you feel about this, whether it be with anxiety or the life stresses they may be having, whether it be cost, I would want to just blind what you're actually seeing, and I will let you know if there's anything emergent. So obviously, if you're seeing a glucose level of 30, you would tell your patients to go to the ED or drink something really fast. If you're seeing a glucose level of 600 or above and your patients are not feeling that great, you give them a call and you tell them to go to the ED because more than likely they're in HSS or DKA.
Thank you for the very informative talk. And one thing I appreciated about your slides is, as a good reminder for a lot of us and even the medical students is, one thing I always tell myself, or I sometimes even tell patients when they're like, oh, I don't have insurance, I always tell them it doesn't make a difference for me whether you're insured or insured, I'll treat you, whatever the guidelines say. But also at the same time, I think you pointed out that to us it's just a button, right? Prescribe this. To somebody else it's rent or, what have you. And so I appreciate that you added that to your slides as a quick reminder for, hey, maybe want to think about what you're doing and think about the cost consciousness.
Absolutely, thank you for that.
Thank you, Tosan. That was a highly relevant subject. We see it commonly, but there's a lot of ongoing advances, so it's great to get regular updates on it. And being solely inpatient, I don't get a lot of exposure to this, and I'm curious to hear more about your exposure to CGMs in the clinic setting, like your prescription of it and your monitoring of it and using it to modify your patient care. Could you elaborate on that?
Yeah, so CGMs really do come into play for two different kind of patient populations. From my experience so far, I like to say baby doctor. But when it comes to patients who have been in the 7.5 to 8.5, right below that hemoglobin A1C of 9 range, where we're trying our best, they're on 3 different anti-glycemic medications. CGMs are actually useful for those patients so we can see their behavior patterns with medications when they spike versus when they do not spike or when they have hypoglycemia. That lets us know more, so like if we should put them on certain insulin management or get them on other medications, especially like GLP-1. medications that can help with that. The other high-risk population that we're now seeing, and we're actually doing a quality improvement project on this with Dr. Parpakar in the office, are patients with hemoglobin A1C above 9, and giving them CGMs as well, so they can also monitor, okay, what am I eating here? Am I doing a 1-to-2, 1-to-5 carb ratio with my insulin management? So they can see themselves how what they do at home is impacting their actual readings. And then that way we can titrate their medications as well in office. Big thing that primary care providers have to take into account is the entire picture. So if a patient comes in, they have hypertension, hyperlipidemia, unfortunately may have CHF and CKD. We have to kind of play the puppet in choosing if we're going to do, GLP-1s, depending on what they've already, experienced, or if we're going to do SGLT2s in order to help with cardio and renal protection. But yes, it comes into play with those major two patient populations for me.
Thanks, Tosan. I thought this was great. This is actually just more a comment for everybody back there. And I'm glad that the cost, I also wanted to comment that I really like that you brought up the cost of these medications. Novo Nordisk very recently, like earlier this week, essentially said that they are now giving Ozempic, cash pay is $4.99. So that's just another, it's slightly cheaper than it was before. Still, very expensive for most people, but $4.99 a month. And I believe they might be doing that for Wegovy as well.
All right. Thank you, Dr. Ejutse. Great presentation.
Thank you. Appreciate it.